Hello and welcome to another Wound Healing Society Fireside Chat, where we feature breaking articles from the Journal of Wound Repair and Regeneration. Kyle, why don't you take it away?
So this week we are featuring Dr. Helen Williams, who is in the Department of Surgery at Westmead Hospital and affiliated with the Vascular Biology Research Centre, the Westmead Clinical School, and the University of Sydney in Westmead, Australia. We're discussing her recent paper in Wound Repair and Regeneration titled Monocyte M1, M2 Profile is Altered in Pediatric Burn Patients with Hypertrophic Scarring. Welcome, Dr. Williams. I'll turn it over to Mitch, and he'll start us off with some questions.
Feel free to jump in, Kyle, if you like. Can we first kind of frame the picture of a hypertrophic scar and talk about the pathophysiology of it?
Yeah, and so these scars are a pretty common outcome of burn injuries in adults and in children. Saying how common they are can be a little bit tricky because depending on the cohort you're working with, there can be quite a range in how often you see them. But generally, people tend to report between, say, 30 and 65% of patients will experience a hypertrophic scar after a burn. And this is quite high in children in particular. And so in children, maybe 75% of them will experience a hypertrophic scar after their burn. In our particular cohort for this study, we found about 50% of them experienced a hypertrophic scar, even though they had fairly minor burn injuries in this instance. Cells, they are raised, they are red, they are disordered tissue, and they can lead to lots of problems for the people who have them. They're not just a cosmetic issue. They can lead to difficulties with movement. They can be itchy, painful, uncomfortable, and they can require quite extensive treatment to either reduce the impact of them or to try and lessen the scar once it starts to develop. It also doesn't develop to mature, and they can expand and change over time. It makes it difficult to know who is going to have these scars and who isn't going to. Now, what the scars themselves look like at, a deeper level is there's a lot of collagen there, and it's quite disorganized. So usually you get nice, neat bundles of collagen in healthy skin or even in a normal scar. But in hypertrophic scars, this collagen is kind of all over the place. What causes this excessive collagen isn't really clear, so a lot of the mechanisms are still under investigation because people really would like to be able to better predict who will develop these scars. There are some sort of population level indicators. So if someone has, a larger burn, then they're more likely to experience a hypertrophic scar. Or if they have a delayed healing of this wound, then they're also more likely to scar. But you don't really know someone's going to have delayed healing until they're having delayed healing. So that doesn't really allow you to predict who will get them. So we're very interested in the cellular contributions to these scars and whether it happened to the cells early on, especially cells that produce collagen, could give you an idea of who's going to develop these scars and help you to either target treatment or even look at some specific markers that you could, intervene with to improve outcome of scarring for these patients.
So I'm much more familiar with chronic wounds, and I'm very familiar with kind of the M1 to M2 transition, if you will, and it's more of a very broader phenotype. I think we think of it very simply as just M1 and M2. But can you talk about kind of the themes around M1 and M2 in burns and how it compares during kind of healing times as well?
Yeah, and so what you see with M1 and M2 in response to a wound is the same as what you'd see in burns. So first, a little bit about the M1 and M2 macrophages. As you pointed out, that's a quite simplistic way of looking at macrophages. There's a whole spectrum of different types of macrophages. M1 and M2 does give you a nice, convenient way of classifying them. And they were originally named these ways because the Th1 cytokines are responsible for making the M1 macrophages, and the H2 cytokines are responsible for making the M2s. The M1s are considered to be inflammatory. They release inflammatory cytokines such as interleukin-6 and TNF-alpha, whereas the M2s are considered to be anti-inflammatory or wound healing. They can secrete things like interleukin-10, but they can also create a lot of collagen, and collagen is one of the things we've focused on in terms of hypertrophic scarring. Now, in terms of how the M1s and M2s change with wound healing, so early on in wound healing, you get that inflammatory response, which is essential to cleanse the wound of any pathogens and debris and other things you don't want there. And then later on, you get the the pre-modeling stage to replace the tissue that's been lost and then to get it as close to normal skin as you can. Usually you get a normal scar rather than exact replacement of normal skin. Now, a study that has taken skin samples various points after injuries, some of which were burns, has looked at the M1 and M2 macrophages at these different stages. What they found is that in normal skin, there is a predominance of the M2 macrophages. Fairly soon after a wound, the M1 macrophages become predominant until they peak at about 7 to 14 days after an injury. And that aligns quite neatly with the inflammatory phase and the early proliferation stage of wound healing. And then they rapidly drop off and are replaced by the M2 macrophages. The M2 macrophages then reach their peak at about 14 to 28 days after the injury, so that's in the later proliferation stage. And then they slowly decrease over time throughout that regeneration and proliferation phases. And so you get a really nice sequential elevation in M1s with early inflammatory response, and then elevation in the M2s after that. And the transition to the M1s, from the M1s to the M2s, is considered to be quite important to get your normal wound healing. So you mentioned chronic wounds, and in chronic wounds, what you tend to get is either an excessive or prolonged inflammatory response that prevents the wound from moving on to that healing stage later. And in terms of something going wrong somewhere along that M1 to M2 transition is also thought to be a contribution to when you will get scarring.
So I want to talk a little bit about lymphocytes and their kind of reduction in burn. So when you have lymphocytopenia, you can see it in both, burns in adults as well as children, but it doesn't seem to, the reduction doesn't seem to correlate with the time to heal, but it may correlate with the morbidity of the mortality of the patient with that has a burn. Is it more correlated to total burn surface?
Definitely.
Okay.
Yeah. All right. So yes, lymphocytopenia is very common after a burn, and even though our cohort had fairly small burns, we did see a proportion of lymphocytes in these patients, so both in the hypertrophic scarring and the non-hypertrophic scarring groups. But they didn't differ between those two groups. So we said that the proportion of lymphocytes doesn't differ with that outcome. But there are other outcomes that you can look at in terms of the burns, one of which you mentioned there is survival. And so one study that has looked at the lymphocyte count after a burn has divided it between survivors and non-survivors. And what they've seen is that the reduction in lymphocytes is greater in the people compared to the. Now, I'm wondering if this might have something to do with the severity of the burn, the total body surface area affected. And that same study that looked at survival and non-divided the patients into people with a higher or lower total burn surface area. So around 20 to 40% of the surface area compared to those above 40%. And they pretty much saw the same pattern as you'd see for survival. So the people who had the larger surface area had a greater reduction in their lymphocytes as a result of their burn compared to the people with a smaller surface area. So yes, it does seem that even though it doesn't equate to the scarring outcome in our study, it does seem to relate to the severity of that initial burn, and it could correlate to other outcomes such as whether someone survives or not. And this makes a lot of sense because obviously you need functional lymphocytes to help fight off infection, and one of the main reasons people will die after a burn injury is due to complications like sepsis.
Sure. So when you looked in your paper, because it was such a low total body surface area, there were very few monocytes that you normally see kind of get mobilized from the bone marrow in your paper. Is that correct? And
well,
and you
given that they didn't differ from what? Oh, sorry.
Go ahead. Sorry, please.
It's probably a slight lag on my end. Yes, so the proportion of monocytes was the same in the patients who had a burn as the controls. And so we didn't see an elevation in monocytes. And it could be related to the severity of the burns because, as you said, they're not very severe burns in this instance, but it also could be about timing of the sample collection. So our samples were collected about 2 weeks after the burn occurred. And studies that have looked at monocyte dynamics after a burn suggest that elevation in monocytes that you refer to is quite a quick response to the burns. So in the day or days you see a big increase in the monocytes, and then after time that can drop off, and it can either return to normal levels or even go below the normal levels in the same way that the lymphocytes go below the normal levels. And so it could just be that because we took the samples about 2 weeks after burn injury, that if there was an initial elevation in monocytes, that it wasn't obvious in our samples because of when we took them. But
Sure.
Of course, the question being the severity of the burns, yeah, I do think that that could have an influence because, again, the paper that had looked at the lymphocyte dynamics after a burn looked at them, at the monocytes as well. And they, again, divided into the survival and non-survival and the higher and lower burn surface area. And what they saw is the initial elevation in monocytes was greater in the people who didn't survive, and it was greater in the people who had a higher burn surface area. And then that drop of monocytes to below normal levels was again more exaggerated in those more severe burns or in the people who didn't go on to survive. And so in our study, it could be that we took the samples 2 weeks after injury and any change in monocytes might have been harder to detect. But it could also be because the burns themselves were not very severe, that any change in monocytes wouldn't be as marked as if it was a more severe burn. Now, I will say one more thing about the monocytes, and that's that we also looked at the monocyte subsets. So we looked at classical, intermediate, and non-classical monocytes. And we did see that the burns group had an elevated proportion of the classical monocytes. Because these monocytes are the ones that are released from the bone marrow, then we do still think that an increased number of those does turn over an increased release of the cells from the bone marrow. So even though we've got those less severe burns and the samples are taken 2 weeks after the injury, we do think that the information we saw does reflect that there is still increased monocyte turnover, increased release from the bone marrow in these patients.
So you talk a little bit about fibrocytes. For the cell biologists in the world, explain the difference between a fibrocyte and a fibroblast, and then go into and then explain why are fibrocytes elevated in HDS.
Yeah, look, I think that is a brilliant question, and I talked a bit with the group about this because it took me a little bit of time to get my head around it. I thought, yeah, but okay, so both of them have fibro, they can both be found in the tissue. How do these cells actually differ? And it makes sense that they have similar names because they do have similar functions and they can both be found in the tissue. So pretty much they are functionally similar, and the main difference is in location. Fibrocytes can be found in the circulation, whereas fibrocytes are in the circulation, whereas fibroblasts are only in the tissue. And in 1994, Bucala coined the term fibrocytes, and this is because they're circulating. They're like leukocytes, and so the term cyte at the end of that. And fibroblasts like cells, so they get fibro at the start. And this is a really good way of describing them, fibroblasts like cells that circulate. But when we're talking about this with our group, my colleague Heather Medbury, who's one of the authors on this paper we're discussing, said, yeah, but the term fibrocyte was actually used by people to talk about fibroblasts historically. So either interchangeably or in slightly different circumstances, you sometimes see the term fibrocyte to describe a fibroblast. So it certainly doesn't make it easy when you're looking at older papers to understand which cells they're actually talking about. Luckily, we're looking forward, and if you want to know in your own models whether you're talking about fibroblasts or fibrocytes, the first thing is to look at where they are. So if they're in the circulation, you're talking about fibrocytes, and that's nice and easy. If it's in the tissue, well, you need to look at what markers it's expressing. They can both express fermentin, but what you'll get that's unique to the fibrocytes is those leukocyte type markers. So CD45 is a leukocyte marker, and CD34 is a hematopoietic stem cell marker, and those are both present on fibrocytes, but not fibroblasts. And these are two of the markers that we use to identify the fibrocytes in the circulation in our study. Now, about fibrocytes in hypertrophic scarring. Well, before my time, our group looked at samples from children burnt and took skin biopsies and looked at the proportion of fibrocytes in those. And they found that if someone went on to develop hypertrophic scarring, they were much more likely to have fibrocytes at baseline than someone who didn't go on. And this is data that's also been shown in adults by other groups. And so definitely a high number of fibrocytes is associated with the development of hypertrophic scarring. Now, I guess the question is why that is or how those cells get there. And we thought because there are more fibrocytes in hypertrophic scar tissue, that chances are there'd be more circulating fibrocytes in people who go on to develop hypertrophic scars because they're in the circulation, then they go into the tissue. But in this study, we didn't have any difference in fibrocytes in people who developed hypertrophic scars and those who didn't. And to be honest, that was slightly disappointing because, you know, when you've got this idea of what you expect to happen, then you don't see it, then you always go, well, obviously we're wrong about that, but there's always an answer even if you don't find it. And other people have talked about another way fibrocytes can get into the tissue, and that's from circulating monocytes. So CD14 positive cells can differentiate into fibrocytes. And when people have taken these CD14 positive cells from different patients and compared fibrocyte formation in vitro, they've shown that less than people who haven't, so more likely than controls. And within people who have been burned, those with more severe burns more readily form fibrocytes than those with less severe burns. And so it seems that when you have more fibrocytes in the tissue, it's because the monocytes are either going in greater numbers, or once they're there, they're more able to form fibrocytes. Now, what actually causes that to happen? To be honest, I'm not too on top of this. TGF-beta1 is important in the recruitment and formation of fibrocytes, and so it seems likely that high levels of TGF-beta1 could be responsible for that increased presence of fibrocytes in the tissue. But there seems to be a little bit of uncertainty about whether this TGF-beta1 is increased in people who have hypertrophic scars or not. And part of it might be due to different types of TGF-beta or how it's measured or things like that. So I guess I would expect that the TGF-beta1 levels are somehow responsible for this increased formation of fibrocytes in the tissue, but I'm not too certain of that area. So I'd have to read a bit more to understand if that is accepted. But I suppose having a level of uncertainty about this is why people are still trying to understand the exact mechanisms for hypertrophic scarring and try to find ways to use those to intervene in the scarring.
Wonderful. Kyle, did you want to ask anything? I lost my email. I'll be right back in 1 sec. Hold
Sure.
on, I got it.
So, what do you see as the next steps for this project? You mentioned, you really looked at a single time point. Are you interested in looking at additional time points or broader ranges of burns?
I would absolutely love to look at additional time points. The problem with a paediatric population, though, is that it can be a little bit tricky from an ethical standpoint. So even to take this one sample we wanted, we had to take it at a time when the children were under anaesthetic, so when they were presenting for burn treatment like debriding and grafting. So there wouldn't be many opportunities in this specific population to take multiple samples. But some studies that have looked at an adult burn population have been able to take effectively serial samples after someone has been burned. They've been taking daily samples to look at their leukocyte counts. So I guess I'm kind of eyeing off whether an adult population would be a better option here, because perhaps since they can give informed consent, and if they were in the hospital for a more severe burn, they might be having fairly regular blood samples taken anyway. So that would be an ideal thing to look at. Because my main focus for research is actually on cardiovascular disease, and we were kind of doing a little bit of a delve into burns here, I'm not sure I'd have the time, money, manpower to do that sort of study. But, if there was an opportunity to collaborate and work on a project like that, I would absolutely love to do that in future, because I think that those M1 and M2 changes over time would be fascinating to see. And so far, studies have looked at different times after an injury, but haven't looked at the monocyte changes themselves over time in the one person. So I think that would be a really good future direction.
And Kyle, I don't know if you've gone, but I recommend the Burn Conference, the Boswick Conference on Maui, and it's one of my favorite conferences for the year. It's in February when this is your winter right now, right, in Australia? But it never gets really cold,
I mean,
right?
if you can call it winter in Australia. We had frost this morning, but yeah, 100 degrees Celsius here, but it's going to get up to quite warm today, to the point that you'll be comfortable in a t-shirt. So yeah, it's winter, but it's lovely here. I don't think they'd let me go to Maui at the moment. We're not allowed to go anywhere at the moment due to lockdowns. No one wants, especially people from my state, to go anywhere, and vaccination in our state isn't great at the moment either. So I don't think I'll be getting to any conferences in person for probably at least another 6 months.
I'm just starting to travel quite a bit. I'm actually in Chicago tomorrow, but not to Europe yet. But as it's wintertime for us, I get Kyle's winter like 2 days later. It's cold in the wintertime here. So anyway, it was wonderful speaking to you. Just a total delight. We thought your paper was wonderful, and we highly recommend anybody would like to follow up with Helen to collaborate on this really important topic. I think that would be wonderful. So tremendous pleasure. Thank you for joining us, and look forward to seeing you at a meeting once we can. Cheers. Take care, and Kyle.
Crossed.
Cheers. Bye.
Thank you. Bye-bye.